Good afternoon. So the session for this afternoon is on tachyarrhythmias. The objectives are as follows. First is we want to give an overview of the full spectrum of tachyarrhythmias. And then we will do a case-based approach on tachyarrhythmias, which we at this point are defining as rhythms faster than 100 beats per minute. And this particularly will be subdivided into three types. We have the atrial tachyarrhythmias, those originating in the atria. We have the narrow and the wide QRS tachycardias with a delineating QRS duration of 0.12 seconds. Now for the first workshop, we will be talking about atrial tachyarrhythmias. So to start off, we have a 35-year-old primi-gravid at 20 weeks age of gestation who started to experience occasional palpitations for 2 weeks. And she had a normal physical exam except for some occasional rhythm irregularity. Shown is her 12-lead ECG, and one will notice that there is the presence of the so-called group beating. However, there is a dominant rhythm, which on closer look is a regular sinus rhythm. The intervals in red show the sinus rhythm intervals. However, there are premature beats indicated by that circle. That is called a premature atrial contraction. If you look closely in the circle, there is actually a P wave superimposed on the T wave. These are the measurements for the various ECG intervals, and most of them are normal except for the presence of the premature atrial beats. Now going to the second case, we have a 40-year-old hypertensive male who presents for a pre-employment check. He has stable vital signs. This is his 12-lead ECG. On the bottom portion is the rhythm strip, and color-coded in various arrows are the different P-wave morphologies. Note that there are 3 different colors indicating 3 different foci of the P wave. The heart rate is less than 100 beats per minute, indicating a normal rate. This rhythm is called a wandering pacemaker. It is a normal variant. Now the third case is that of a 65-year-old hypertensive male who is a heavy smoker and alcohol beverage drinker, presenting with shortness of breath on exertion, cough and fever at the emergency room. His ECG looks quite bizarre with a very irregular rhythm. And at first glance, one might be tempted to think that it is atrial fibrillation. But again, when you look closer, there are actually P waves and P waves of varying morphology. Now, the difference between this ECG and that of the wandering pacemaker presented earlier is that this ECG presents with a rapid rate faster than 100 beats per minute. This is called a multifocal atrial tachycardia, common among patients with chronic lung disease. Shown again are the intervals. One will note that the rate is rapid. The PR interval is usually variable because depending on the P wave that presents, but the rest of the intervals are usually normal. Now we go to atrial fibrillation, which is actually the most common tachyarrhythmia among adults. Around 10% of seniors have this rhythm. It is associated with heart failure and stroke. It is characterized on the ECG by the absence of P waves, or if some are seen, they are described as fibrillatory and not organized. The atrial rate in this rhythm is commonly 350 beats per minute or higher. The ventricular rate may be fast, controlled, or slow, and the PR interval hence cannot be measured. It is closely related to a cousin rhythm called atrial flutter, another type of atrial tachyarrhythmia where the atria are pumping at 300 to 350 beats per minute. And in atrial flutter, you have the sawtooth appearance representing the flutter waves. Now, the flutter may be conducted to the ventricle in various ratios. So if it is a 2-to-1 conduction, one will have an a ventricular rate rather, of 150 beats per minute. If it is a 4-to-1 conduction, the ventricular rate will be 75 beats per minute. And then you can also have a flutter with variable conduction. Now let's go to the second workshop involving supraventricular tachycardias. And at this point, we need to delineate the difference between a wide and a narrow QRS. This is a normal sinus beat with a narrow QRS. When we talk of wide QRS, the duration is more than 0.12 seconds. Now, in narrow QRS tachycardia, you have a fast rate with a QRS duration of less than 0.12 of a second. Now, pathophysiologically, one may then define supraventricular tachycardia as a tachycardia with the focus or the circuit which is fully or at least partially above the bundle of His. In terms of mechanism, it may be focal, indicating it is coming from a focus, or it may be involving a circuit in any part of the atria or the parts of the conduction system above the His bundle. In terms of ECG recognition, the common diagnostic problem with ECGs in SVT are the P waves may be a bit difficult to discern. But the rate will usually be 150 to 250 beats per minute, the rhythm regular. The reason the P waves are difficult to discern is they may be buried in the preceding QRS, in the ST segment, or in the T wave. The QRSs are usually narrow unless the SVT is aberrantly or slowly conducted. Now, what is the summary of that first ECG? Okay, so here we have a narrow QRS tachycardia. The rate here is around 160 beats per minute. And at first look, it may be difficult to discern the P waves. But if you look closely at the ECG leads, one can then determine that there may be actually P waves following immediately the QRS. These are the so-called retrograde P waves. Now then, let's try a little bit of a quiz. How does one then narrow down the diagnosis based on this particular ECG? The first thing we can rule out is it is not atrial fibrillation, because when you say atrial fibrillation, it necessarily means an irregular rhythm. It is not sinus tachycardia, because you have seen a lot of sinus rhythm and sinus tachycardia ECGs. It looks very far from this. So now we are left with SVT and atrial tachycardia. So the clue here is if the P waves are hard to discern, or if they occur soon after the QRS, then you can probably bet it's an SVT rather than an atrial tachycardia. Okay, so we have this algorithm that may help us narrow down the particular type of SVT. So the starting point in the algorithm is a narrow QRS tachycardia. Again, as a reminder, it is a rhythm faster than 100 beats per minute, where the QRSs are less than 0.12 of a second. So the first question in the first diamond to ask is the tachycardia regular or not? If it is not, then the diagnosis is automatically atrial fibrillation or some form of atrial tachyarrhythmia. If it is regular, then one is left with two possibilities. It can be an atrial tachyarrhythmia or an SVT. So now you need to look for the P waves. Are the P waves visible? If you do not find P waves, or you find it hard to discern the P waves in a regular tachycardia, it's probably SVT, in particular AV node reentrant tachycardia or AVNRT. Now, if you see the P waves, you have to count, are there more P waves than QRSs? If yes, then it's probably an atrial tachycardia or an atrial flutter. Now, if there are equal P waves and QRSs, here is where you already need to turn to the so-called RP interval. Because the RP interval will help you differentiate between SVT versus atrial tachycardia. And shown in this slide is how to measure the RP interval. In red is the start of the R wave, and in blue is the start of the P wave. The interval between red and blue is the so-called RP interval. It is considered a short RP tachycardia if the RP interval occupies less than half of the RR interval. On the other hand, it is a long RP tachycardia if the RP interval occupies more than 50% of the RR interval. The differentials for long RP tachycardia are atrial tachycardia and sinus tachycardia. For short RP tachycardia, it is commonly SVT or supraventricular tachycardia, in particular AV node reentrant tachycardia or AV reentrant tachycardia. Okay, so for that first ECG, the summary diagnosis would be SVT, short RP type, probably ANVRT. Okay, now this is a laddergram, and I will introduce you to the concept of the laddergram. The laddergram is a graphical representation of the flow of electricity in the heart. There are three tires, A for atrial, AV for AV node, and V for ventricle. So here in AV node reentrant tachycardia, we will see that the forward arm or anterograde arm utilizes the slow pathway in blue, and the green pathway is the fast pathway representing the retrograde conduction. In AVNRT, you have a sudden onset and termination. The rate is commonly 150 to 250 beats per minute. You have a normal QRS contour. There is the presence of a pseudo S in leads 2, 3, and AVF, and a pseudo R prime in lead V1, all representing retrograde P waves. Okay, now we can go to the next case. Case 2 for supraventricular tachycardia is found in a construction worker who comes to the emergency department for palpitations. He has no dizziness or presyncope, blood pressure is stable, heart rate is in the 160s. Again, like the first case, you see it's a narrow QRS tachycardia, and one has to strain really hard to find where the P waves are. Sometimes you may have to use a magnifying glass, like so. And here you can see that right after the QRS are inverted retrograde P waves, suggesting a diagnosis of supraventricular tachycardia. Now, this particular patient underwent a cardioversion. He was converted back into normal rhythm, and this is his ECG after conversion, and it shows two peculiar signs. One is the presence of a delta wave or slurring at the start of the QRS, and the second is the shortened PR interval, both diagnostic signs of Wolff-Parkinson-White syndrome or WPW. Now, this is the laddergram in orthodromic AVRT. The antegrade limb is through the AV conduction system in red, and the retrograde limb is through the accessory pathway in blue. Okay, now we can turn to our third workshop, wide QRS tachycardia, which again we will define as the presence of QRSs more than 0.12 with a focal or reentrant mechanism. So a ventricular tachycardia is defined as a wide QRS tachycardia of at least 3 beats. It is usually associated with structural heart disease. The rate is 100 to 260 beats per minute. Commonly, there is the so-called AV dissociation, and the QRSs may appear wide and bizarre. Okay. Now, these are the commonly cited features that may help differentiate ventricular tachycardia from supraventricular tachycardia with aberrancy. The clues may include QRS width, axis, regularity, presence or absence of concordance, the QRS morphology criteria, the presence of AV dissociation, and fusion or capture beats. Now we mentioned repeatedly that the cutoff QRS is 0.12 second, but if the cutoff QRS hits 0.16 second, that favors ventricular tachycardia over SVT with aberrancy. Aberrancy is defined as slowing of conduction of a supraventricular rhythm through the normal AV conduction system, leading to QRS widening. Now, the presence of abnormal axis, meaning if it is less than 0 degrees or more than 90 degrees, would tend to favor more of ventricular tachycardia. Regularity. If the wide QRS tachycardia is regular, then it is likely either ventricular tachycardia in 80% of cases or supraventricular tachycardia with aberrancy in 20% of cases. If it is irregular, then as mentioned earlier, it is probably atrial fibrillation. Now let's talk about concordance. Concordance means agreement in the direction of the QRSs when you look from V1 to V6. If all QRSs point upward, that is positive concordance. If all QRSs are pointing downwards in V1 to V6, that is negative concordance. The presence of either favors more of VT over SVT with aberrancy. Now, the most useful criteria I find, because you can apply it to all patients, is the use of QRS morphology. The basic principle when using the morphology criteria is to determine whether the morphology is typical, meaning it looks like the usual bundle branch block, or atypical. So it stands to reason that you need to know what typical right bundle and left bundle branch block looks like. So in typical right bundle branch block, you have a rabbit ears morphology in V1, with the second rabbit ear being taller. And in V6, you have small slurred S waves. Now for left bundle branch block, you have widening of the QRS with a mid-intrinsicoid deflection and STT waves opposite to the direction of the QRSs. So in atypical morphology, you will have all other, whether it be a QR, an RS, anything that does not look like typical is called atypical and is consistent with ventricular tachycardia. AV dissociation is a very specific criterion for VT. If it is present, you're almost sure that it is VT. In AV dissociation, you can find P waves marching through the whole rhythm strip. Now, we mentioned fusion and capture beats. A capture beat means it looks like a sinus rhythm beat. It indicates that the sinus is able to interrupt the run of ventricular tachycardia, whereas the fusion beat is a hybrid between the capture beat and the wide QRS VT beat. The presence of fusion or capture beats is highly suggestive of VT. Now, how do we put everything together? The most popular algorithm is that designed by Brugada. And it is a stepwise approach where one runs 4 criteria and decides whether it favors more of VT or SVT with aberrancy. First criterion, absence of RS complex in all precordial leads. This is another way of saying concordance. So if there is concordance that favors, we mentioned earlier, VT. If there is no concordance, then it can still be SVT. Second criterion, RS interval more than 100 milliseconds or 0.1 second. That is actually called the Brugada criterion. If it is present, that favors VT. If it is absent, then that favors SVT. Third criterion, AV dissociation. We already defined that earlier. When present, highly suggestive of VT. When absent, that would favor SVT. And finally, the most popular, the morphology criteria. When the morphology criteria are atypical, that favors VT. When they are typical, then that favors SVT with aberrancy. So in summary, narrow QRS tachycardia is almost always SVT. If it is irregular, think of atrial fibrillation. If the narrow QRS tachycardia is regular, check the RP interval to narrow your diagnosis. Now, wide QRS tachycardia, on the other hand, is VT in 80% and SVT with aberrancy in 20%. If it is bizarre looking, it is probably VT. If there is structural heart disease, then it is better to assume that it is VT. Thank you.